Chapter 15 continued. Trauma, mobile, and surgical radiography. Slides 29 through 36 are all review. Please look over those for your test on Tuesday. Attributes of the surgical technologist. They need to have confidence in their abilities as a technologist. They need to have mastery of all aspects of radiography, problem-solving skills, ability to respond quickly and correctly to changing situations, communication with all members of the surgical team. The surgical team includes the surgeon, the certified surgical technologist, or CST, the radiologic technologist, the scrub nurse, or CST or RN. Also not listed would be the anesthesiologist or the nurse anesthetist. The scrub tech of the surgical team prepares and maintains sterile surgical field and instruments, gowns members of surgical team, and anything else that's asked of them. Radiation protection with C-arm. Place X-ray tube under the table to reduce head and neck exposure of the operator. Remember that on a C-arm, the smaller end is where your CR will be. Minimize use of boost exposures. Minimize distance between anatomy and image intensifier. Provide lead aprons for those remaining in the area, not behind lead shields. The surgical environment, sterile versus non-sterile environments. What should you do if you slightly brush against a sterile drape in surgery? You should always notify the team, the surgical team, that the sterile field has been contaminated. Surgical asepsis, separation between sterile and non-sterile areas. Always know what is sterile and what is not sterile, so that you know what can be touched and what cannot be touched. There are 3 methods protecting the sterile environment: draping the C-arm, draping the patient, or a shower curtain. The image on the left, draping C-arm with sterile plastic. The sterile plastic usually comes from the scrub tech or the instrument tech. They come and they put it over the IR portion of the C-arm. You get the back side and you're able to tape it to the rest of the C-arm, or you can tie it in a knot. As long as you don't touch anything that is around the IR or covering the IR, you are safe to touch the bottom part. On the image on the right, draping C-arm with a snap cover. This is something new to me. I've never seen a snap cover before, but it appears that the sterile individual, or should be sterile individual, you'll notice he's not wearing a cover over his hair, but he is draped in blue and wearing sterile gloves, putting on a snap cover. How they keep this snap cover sterile, I have no idea. It would be a good question for somebody to research. Use of sterile cassette or IR covers. The image on the left is the technologist placing the IR into the sterile cover that's being held by the scrub tech. After the scrub tech has the IR in their hands inside the sterile plastic, they can place that IR wherever you need it to go. Once your exam is completed, you will remove the IR from the sterile cover as shown in the picture on the right. Surgical attire for technologists: scrubs, shoe covers, non-sterile gloves, protective apron, head cover, and a surgical mask. Operative cholangiogram, conventional mobile X-ray unit position for AP projection, centering point indicated by the surgeon. In the image below, you see an actual mobile unit positioned over a sterile field. I'm not sure where they get this, but this is usually done under or with a C-arm, a sterile field, and that mobile unit is not sterile. So the image is incorrect, but for sake of the boards, you need to see this slide. Evaluation criteria for an operative cholangiogram. Entire biliary ducts filled and demonstrated, no motion, optimal exposure factors included. Retrograde urography, conventional cystopic table and X-ray unit. In this image, you see the technologist placing a IR into the table where they are imaging. Although this appears they're putting it at the head, and then it should be at the abdomen. Not sure how old this information is as far as the X-ray unit they're using. This appears to be a mobile unit. We do retrograde urography with a C-arm. It is not a sterile field because the entry point is usually through the urethra, which is not a sterile area. On this slide, you will see external fixators on the left. These are attached to the bone on the inside of the body. On the right, you have external fixators that are attached to the bone, but most of your metal is going to be on the outside of the body. On this slide, on the left, you have a pelvic external fixator. And on the right, you have a variety of intermedullary rods and nails. Hip fractures and pinning. Types of proximal femur fractures, you have the femoral neck, comminuted subtrochanteric, and intertrochanteric. You can visualize these on the left. Your femoral neck is going to be A, your comminuted subtrochanteric is going to be B, and the intertrochanteric will be C. On the left, you have internal fixation of fractured hips with cannulated screws for non-displacement femoral neck fractures. Hip pinning procedure. On the left, you'll see the C-arm is set up with a fracture table. A fracture table allows them to place one leg up and out of the way. That leg is the side that is unaffected, and the side that is affected is held straight out with the foot attached to another device to hold the leg in place. They're able to move the leg in and out and put it in the position that is feasible to get an internal fixator in appropriately. On the right hand side, if you look closely, you can see the plastic that is from the top of the image down to the bottom of the image. That is what's called a shower curtain. It separates the sterile field from non-sterile areas, and this way that you can use the C-arm without having to drape it. The image on the left, the C-arm alignment for lateral hip, recommended C-arm position for intensifier near the surgeon. On the right, the C-arm alignment with the X-ray tube near the surgeon is not recommended. This is due to the amount of radiation that the surgeon would get. On this side, you see what the internal fixators, or rather screws, look like when you're doing a hip pinning. This is an AP and lateral post-operative radiographic images with internal fixators in place. Lumbar laminectomy. On the left, you have C-arm set up for an AP projection. The patient is prone. And on the right, C-arm alignment for a lateral projection. Lumbar laminectomy or fusion. This is post-operative images of what a laminectomy / fusion will look like. On the left, you have an AP projection, and on the right, you have the lateral projection. Scoliosis corrective surgery. Scoliosis, AP, and lateral projections preoperative. You'll see those images on the left. AP projection postoperative with Harrington rod in place on the right. Pacemaker insertion procedure. PA lateral chest, postoperative projections with pacemaker in place. When you're doing these exams for post-op, the patient's usually in an arm sling because of the area that they where they put the pacemaker at. They do not want anything messing with the muscle, or they put the pocket for the actual device. So you will do a lateral with the arm down, and when you do the PA, you do not want to move the arm. You can move the shoulders forward, but do not move the arm from the abdomen area.